So we're presenting the data that we, for the Delphi consensus last year, and the focus was what to do after focal therapy. How should we follow these patients after? Again, that was a consensus meeting hosted by Dr. Okimura, who's sitting in the back in Kyoto. There were two things we wanted to basically have a consensus. One was to find a standardized nomenclature, and the second part was to establish a uniform follow-up. I think it's important, we all agreed it's important to have a uniform template to follow up patients, to generate reliable data and basically do good science and to justify this treatment modality in the future. So Delphi consensus, I think there were already two presentations here. Basically, it was a questionnaire. It's going to distribute it to a panel group of people, experts in the field, most likely. November 20th to February 7th, 2019 was the time frame we distributed the survey. We used the SurveyMonkey platform. The panel members were sent the question in 3 rounds. Each round, they were presented with the results of the previous rounds, and the questionnaire were a little bit modified based on the feedback we got. And in order to get consensus, we thought that this is basically in the Delphi methodology, getting 80% people respond the same answer. That's defined as a consensus. So we had an excellent response rate. The first round, we had 91.4%, 89, 86 in the third round. It came a little bit down, but still very robust for a Delphi consensus. These tables basically show the demographics of the experts. 2/3 were urologists, 72% urologists, 1/3 radiologists, so it's interdisciplinary. And the modality, they used everything from HIFU, cryo, laser, IRE, radiotherapy, PDT. I think we cover all different treatment modalities. And those are the numbers on the right side, the experts, patients they treat with focal therapy. So at least 75% treat more than 10 patients. The vast majority treat between 10 to 50 patients. Just for completion, this is the table we included in our paper. So I want to emphasize it was an interdisciplinary, urology and radiology, international, as you see, Northern America, South America, Europe, and Asia, and basically people from all over the world were participating in this study. It was concluded with a face-to-face meeting in Kyoto, Japan, and these are the panelists in Kyoto, Japan. So first, the standardized nomenclature. There was over 90% agreement that focal therapy itself, the terminology, should be just used for an image-guided, focused ablation of an image-visible lesion, biopsy-confirmed malignant lesion, plus an adequate safety margin. At the same time, there's partial gland ablation, which is basically an image-guided ablation of an image-visible lesion, applying a template. And the templates are listed here: a quadrant ablation, a hemiablation, a hockey stick ablation, a subtotal ablation. I'm going to show you guys a figure in a second. But then what should, in terms of focal therapy, what is the index lesion that should be ablated? We agreed that all biopsy-confirmed lesions with clinically significant prostate cancer, meaning Gleason grade group 2 or higher, should be used as an index lesion for ablation. We should not use just based on size, meaning the largest volume, not the highest Gleason score, nor any Gleason grade group 1 for ablation. And this is the figure from our paper. On the top, you see the focal therapy of the prostate. Basically, it's an image-guided treatment of the lesion itself, plus a safety margin. Previously, there were Delphi consensus that say at least 5 millimeters we should use as a safety margin. And then below that, you see a partial gland ablation templates. It's a quadrant ablation, hemiablation lateral, or hemiablation just the anterior part. Obviously, posterior, we don't think it's ideal because there's a neurovascular structure. Then there's a hockey stick ablation and a subtotal ablation. Okay, so now we tried to, that was the consensus for the nomenclature. The next thing we tried to look at was to find a uniform follow-up for these patients. So the question were laboratory, what laboratory tests should be gotten after focal therapy? Imaging, what kind of imaging should we get? Biopsy, what type of biopsy? Systematic target biopsy. And quality of life, what should be assessed after focal therapy? And Okay, so laboratory, there was 98% of the surveyed participants said that PSA is still the best non-imaging biomarker. Some people consider MRI as a biomarker, so the best non-imaging biomarker is still PSA in surveillance. There is still a role in getting PSA to evaluate oncological success, but there was also agreement that oncological success cannot be determined by the PSA. In terms of imaging, 96% of the panels agreed that MRI is the preferred imaging modality at this time, and DCE is the primary sequence to determine failure. And what we are going to look for is an early focal contrast enhancement in DCE. We got 80% of respondents saying that's the best and most reliable image modality sequence we should look for failure. In terms of biopsy, there was a question, should we just biopsy the targeted region or everything in the biopsy? So post-treatment biopsy must include both a targeted biopsy to evaluate the treatment and a systematic biopsy to evaluate the rest of the prostate. So the first biopsy should be obtained 6 to 12 months after treatment. And finally, quality of life. The first time assessed at 3 to 6 months post-treatment. There was 93% agreement on that. In terms of erectile function, we couldn't get a real agreement. Some people said there should be no change from baseline, and others said that should be considerable suitable for intercourse is good enough for failure. In terms of continence, we all agreed that they must have no pads. Basically, that's considered success. And urinary symptoms should definitely be assessed after focal therapy.
Can you wrap it up?
Okay, I'm almost done. Assessing the success and failure after focal therapy, the in-field failures, treatment failures, to get a targeted biopsy, and as well as a systematic biopsy to look for screen failures. So post-treatment biopsy must include both the targeted biopsy of the treatments and the systematic biopsy. And this is basically the summary recommendations from our paper, and that's about to be published. So we distinguish between what the first time we should assess for PSA imaging biopsy and assessment of functional outcomes. And then we all agreed that 5 years this should be followed, and this is basically the schedule for follow-up. Okay, lastly, post-procedure management. Successful treatment is eradication of all Gleason grade group 2 and higher. No further treatment is required if that's the case. Careful monitoring. If you have Gleason grade group 1, after focal therapy, just put them on an active surveillance protocol. In-field failure can be retreated if inadequate treatment was done, but you need to know what was wrong. And out-of-field failure, screen failure, could also be offered repeat focal therapy, but the condition is that you see it on imaging and can actually go after it. With that, I want to thank Dr. Pinto, who's my mentor at the NIH and support throughout, Dr. Polasek, and Dr. Okimura and Dr. De La Rosette for the excellent meeting in Kyoto and letting me doing this consensus. And finally, Dr. Rastina, who has been a pain throughout this process, but very supportive. Thank you very much.